Okay, we've just started recording. So, well, good afternoon, everyone, and welcome to Paediatric Teaching. Today, I wanted to talk about the identification and management of the deteriorating patient. It's a very common scenario that we see in hospitals, a daily occurrence, really, that patients would. I'm just going to. Could you please mute your devices as we go along? Look, this is a really common scenario, the deteriorating patient, and I feel like we don't have much discussion about it. We don't teach medical students or registrars how to identify and prevent and manage the deteriorating patient, and yet we see such patients every day in all hospitals. And just to give you an idea of how common this is, it's very common that paediatric patients who die or subsequently need intensive care show some signs of physiological or behavioural disturbance before they arrest or collapse. And it's at that time when they're showing some signs of physiological disturbance, some deterioration in their vital signs or a change in their behaviour, that it's possible to be able to pick up the patient who's deteriorating. It's a skill that has to be learnt, but it is possible to pick up the deteriorating patient. And I think we need a bit more emphasis on how to identify and prevent and manage the deteriorating patient. So that's what today's talk is all about. So let's go. The deteriorating patient could be almost any patient that we see. Commonly, the child who's got meningitis, whose conscious state worsens, or who has a prolonged seizure and they go from being semi-conscious or conscious to being unconscious. That's a deteriorating patient. The child with pneumonia who becomes more hypoxic after they come into hospital, for some reason they get worse. That's a deteriorating patient. A child with dysentery who goes into shock from dehydration that we haven't quite kept up with, or develops infectious sepsis from their dysentery, that's a deteriorating patient. The child with malaria who goes into heart failure from anemia, a progressive condition that can lead to some deterioration, that's a deteriorating patient. We see children with severe malnutrition who develop shock from sepsis. When they first come in, they might have diarrhea, they might have a fever, an infection, and they develop shock. That's a deteriorating patient. Sometimes we see children with osteomyelitis or some staphylococcal infection somewhere, and then it spreads to other organs. That's a deteriorating patient. And then even in the neonatal ward, there's lots of deteriorating patients, isn't there? Then the newborn baby who's got some birth asphyxia, who develops pulmonary hypertension and then develops apnea, that's a deteriorating patient. And the low birth weight baby who develops heart failure from a PDA or from anemia, that's a deteriorating patient. So every day in our hospitals, we're seeing many children who are potentially deteriorating patients, and we just need a systematic way to identify these patients and to prevent their deterioration and to manage it if they deteriorate. You can think of other examples, I'm sure, that you've seen in the last few weeks of children who've deteriorated. As I said, it's a daily occurrence in hospitals, and it can be from any disease or combination of diseases, from acute illness or a child with a chronic condition with some acute complications, or because a child with a chronic illness or an acute illness has comorbidities where they may have unrecognized anemia or unrecognized severe malnutrition, or on top of their chronic illness, they may have developed an infection. So that combination of acute on chronic with comorbidities is a common reason why children deteriorate. Now, as I said, deterioration is often a precursor for poor outcomes. What that means is deterioration precedes poor outcomes, and usually the signs of that deterioration present well before the collapse. Before the child collapses, before the arrest, usually a combination of vital signs, maybe just one vital sign going bad, but usually a combination of vital signs. And we as paediatric doctors and nurses, we need to be experts in detecting the deteriorating patient and preventing that deterioration. And there are ways you can there are systems you can put in place and skills you can learn to detect deterioration. So that's what we aim to learn today. We have talked before about the stages in the management of any sick child, and these are the stages that WHO says should be part of the management of any sick child. So triage, emergency treatment, history and examination, laboratory investigations, the main diagnosis and other diagnoses, so like a differential diagnosis sometimes or other alternative diagnoses, providing treatment, and then supportive care, monitoring, discharge planning, and follow-up. These are the stages that every child who comes into the emergency department or gets admitted to hospital really goes through. And there are many opportunities during that a child's admission to detect the deteriorating patient, especially at triage, but also during the history and the examination. And then as we're monitoring them every day, we can detect the deteriorating patient. So as part of the overall stages of management of any sick child, there should be opportunities to detect the deteriorating patient. WHO says these are the emergency signs which we have adopted if a child has obstructed breathing or severe respiratory distress or central cyanosis or signs of shock or coma or convulsions or severe dehydration. Then there are emergency signs, and there are also signs of deterioration, a child who's deteriorated from their normal baseline. So these are signs that we can use to detect a deteriorating patient. The question is how to do that. And there is a relatively easy way at triage or when you're doing your ward rounds to detect those emergency signs. So if you get used to doing this on a regular basis at triage, you take a very brief history of the presenting problem, you take the temperature and weigh the child. These are important, just basic things to do. And then in terms of the detecting emergency signs, for the airway, you listen for stridor or obstructed breathing. You listen and look really, don't you? And you look for cyanosis and check for signs of respiratory distress, such as chest indrawing or tracheal tug, and check their oxygen saturation if they've got any signs of respiratory distress. And then for the circulation, you feel the skin temperature of the hands and feet. You feel the pulse volume and you check the capillary refill time. I find it's very useful to feel a patient's hands and feet, because when you do that, if you feel a patient's hands, you're feeling the skin temperature, the peripheral temperature, you're feeling the pulse at the same time, and you're checking the capillary refill. And if you get good at that, then you'll be able to know what the pulse volume should feel like, what the skin temperature should feel like in a well child, and what it feels like in a child with shock. And you can check the capillary refill time. And then you assess the child for lethargy or degree of unconsciousness, and so you assess their conscious state. That's what you can do at triage to assess for emergency signs. I wanted to now just talk about a case. I'm going to give a case example, and there'll be two alternative scenarios. And the first scenario that I'm going to present is what I've commonly seen, and then the second one is how we should do it. And I'll just go through the case very briefly, and we'll talk about this. This is a case of a child who, with a very common problem that you will have seen in your hospitals, and I want you to think, how would you manage the patient? So this was a young girl, Joy. She was a 7-month-old girl with respiratory distress, cough and respiratory distress. She'd been unwell for about a week. She presented with cough, fever, and she was unable to feed. She presented to the emergency department with cyanosis, and she had oxygen saturations of 82%, but they increased to 92% on oxygen. She was started on benzoyl penicillin intramuscularly and then admitted to the ward. Her parents were very worried about her high fever, 39.2 it got to, and they kept telling the nurses and the doctors how worried they were, especially about her fever, but also about her not feeding and her degree of respiratory distress. Her parents stated this on several occasions in the first 8 or 12 hours that she was in the hospital. She was given antibiotics on admission, the right sort of antibiotics you'd imagine, but she remained febrile and tachycardic, and tachypneic, and that increased. Now, this is a paediatric monitoring chart, and I'll just go through it. This was her temperature. Hope you can see that more or less, but her temperature was, as I said, 39.2 when she came in. It was in the above 39 most of the time. It came down briefly to 38, but never got to normal, and then it went back up to 39. You can see maybe just up here, and it stayed at 39 all night. Almost every time the temperature was taken. There were 1 or 2 times the temperature wasn't taken, but mostly it was very high all night. This is her Joy's respiratory rate, and you can see it started about 60, and then it went up to 70, and then even up above 80. And for much of the night, she came in at 1600 hours, so 4 o'clock in the afternoon, but for much of the night, her respiratory rate was above 80. There was, again, a couple of times when it wasn't checked overnight, but mostly it was recorded as being above 80 overnight. Her oxygen saturation was okay at the start when she was on oxygen, 91 or 92%, and then it dropped down a bit, and then it dropped down even further in the early hours of the morning and throughout the morning, and it was quite low, even in the high or low 80s for some of the morning. The oxygen amount she required was increasing throughout the 24 hours that she was in the ward. So it went from 1 to 2 litres per minute to 3 to 4, and then even at in the afternoon the following day it went up to 6 litres. Her respiratory distress was recorded as being moderate to begin with, and then it was recorded as being severe for much of the time she was in hospital. In that, this is only a 24-hour period. So she came in at 1600 hours at 4 o'clock in the afternoon, and she arrested at 2 o'clock in the following afternoon. Her heart rate started off at 160, so still high for her age, but then it went even higher and went up into the red zone, and then it only dropped down to a much lower rate around the time 2 o'clock in the afternoon. The capillary refill was okay for most of the time, but then in the last few hours it became abnormal. Her blood pressure was all right for most of the time, but again, just before she had an arrest, her blood pressure fell. But she remained alert for most of the time, except when she had deteriorated. So she was given antibiotics, but she remained febrile and tachycardic and tachypneic. And her oxygen requirement increased throughout the night. And the following day on the ward round got to her around about 11 o'clock, and it was noted that she was gasping. And then she was given more oxygen around this time at 4 litres. And then she had a respiratory arrest just less than 24 hours after admission. It was 22 hours. And yes?
The registrar.
No, it's next door.
All right.
Yeah. She, at that stage, she was intubated and had CPR performed, but unfortunately, she couldn't be resuscitated. So this was a child who came into hospital and within 24 hours went from just being okay with some of the vital signs being a bit abnormal to being quite showing deterioration in many of her vital signs, and then having an arrest. And this is a common scenario, isn't it? Now that's one scenario. This was a chest x-ray at the time that she deteriorated at midday in the afternoon. Can anyone tell me what is going on with her? We said at the time she came in, she had pneumonia, but can anyone see what's actually happening? What do you think is happening?
Effusion?
She's got an effusion, hasn't she? A pleural effusion, that's right. And is it a small one or a large one?
Let's see.
It's a large effusion, and it could account for why she remained so tachypneic, why her oxygen saturation fell, why she became tachycardic, all right? And so this was a child who deteriorated within 22 hours of coming into hospital, a progressive decline in her vital signs, and it was because she had a large left-sided pleural effusion that wasn't detected. I want to just explain now what actually happened. This is an alternative scenario, what actually happened. And this is what actually happened to Joy. Well, she was given antibiotics on admission. She was admitted at 1600 hours, and she did remain febrile and tachycardic and tachypneic. Her parents were very worried about her fever and her difficult breathing and her poor feeding. And then at 10 o'clock at night, you can see her respiratory rate goes up, just like I showed you before, and it gets into the red zone. Her oxygen saturation drops, gets almost to the red zone, to the orange zone. Her heart rate goes up. Her capillary refill is still okay, and her blood pressure is still okay. So the things that have changed are her respiratory rate and her oxygen saturation. So what happened then was there was what's called a MET call, a medical emergency team call, because some of her vital signs were in the danger zone. Her respiratory rate and her oxygen saturation and her heart rate was rising. And so this was the MET, the medical emergency team, came, and this was attended by a senior paediatric registrar, the nurse in charge of the ward, and even the anaesthetic registrar came down. And they assessed Joy at that particular time. They decided to increase her oxygen. They moved her to the intensive care area in the ward, the high dependency area in the ward. They got an urgent chest x-ray. This was 10 o'clock at night after she'd been in hospital for only about 6 or 8 hours, not 22 hours like I showed you before. They got an urgent chest x-ray and they found the large effusion on the left side. They found the large effusion on the x-ray. They drained the effusion with an intercostal catheter, and they got 300 mils of thick pus. They used some ketamine to insert the intercostal catheter, so they kept her breathing during the time. And then you can see that her vital signs started to show signs of improvement. Her respiratory rate came down, her oxygen saturation came up, her heart rate came down. This is what really happened. This was the yellow line is where the MET call was made, and that was based on her respiratory rate being high and her oxygen saturation falling. And so after that, she stabilized a lot on a bit more oxygen, but even in the coming hours, she needed less oxygen. This is what happened. She didn't arrest at this point. Many hours before, she had an intercostal catheter inserted, and that drained a lot of the pus. Of course, her lungs are not normal. It hasn't made her completely well, but it has stopped her having an arrest, which was going to happen if she didn't have some intervention. And the intervention was based on just these small changes in her respiratory rate, in her oxygen saturation, and her heart rate. And the MET call was made by the nurse who was looking after her. And that caused a senior paediatric registrar, the nurse in charge, and the anaesthetic registrar to all come to the bedside and make an assessment. And that's what's needed for the deteriorating patient. So Joy stabilized then. Her fever decreased over the next 24 hours. Her respiratory rate had decreased by the morning. She looked much better. And so instead of arresting the next day, she had stabilized a lot. From the pus, we cultured Staph aureus, so the common cause of, one of the common causes of effusion or empyema. And so she stayed on flucloxacillin. She had been changed during the MET call to ceftriaxone and flucloxacillin from just penicillin. The intercostal catheter stopped draining after 3 days. It stopped draining the effusion, and it was removed at 5 days. And then she received 10 days of IV flucloxacillin, and that was changed to oral flucloxacillin for another 10 days. After a day or so, she was taking breast feeds well, and she was discharged after 2 weeks, and she was followed up after 2 weeks to check her respiratory function, her vaccinations, etc., just to see that all was well. So you can see 2 alternative scenarios, one where a child continues to deteriorate and have an arrest, and then it becomes unresuscitatable and dies, which we've all seen, and the other one where, based on physiological changes, the deterioration is detected and further deterioration is mitigated by some interventions, changing antibiotics, draining an infusion, all the things that are needed to just fix her up a bit better than what she was. The medical emergency team system is something that's now become almost universal. Almost all countries have some sort of medical emergency team, and it's usually based on WHO emergency signs and on color-coded monitoring charts like I showed you, so that you can detect when a child goes into the red zone and you can call a MET based on that. And on parents' concerns, in the alternative scenario I explained to you about Joy, her parents, listening to her parents' concerns was an important part of the nurse who was looking after her calling the MET. All right, it wasn't something that the parents' concerns were ignored. The nurse who was looking after Joy listened to the parents' concerns and realized that they were right in what they were concerned about, and the vital signs confirmed that. So a medical emergency team really requires a MET call and an escalation of response. So you get people at the bedside who have some skills in the assessment of the critically ill child. So the MET team can be relatively small, a relatively small team, usually a senior registrar or a paediatrician, someone who's skilled in the assessment of the critically ill child. It can be the paediatric doctor who knows the patient, and ideally it should be a senior nurse, a nurse in charge of the ward, who all come together and discuss what can be done for this child because they seem to be deteriorating. There are many different types of MET systems. I like a simple system. I think there are many, if you read up the international literature on MET systems, there are many studies that have been published, and some of the terms you'll hear are pediatric early warning signs, so-called PEWS, or PTTS, pediatric track and trigger, or RRS, rapid response systems. They're all the same. They're essentially the same concept, and that is they're based on the recognition of deterioration in physiological parameters. And there's been many, many studies. So 34 different types of early warning systems and 55 different studies, and they all show an improvement in outcomes when you have some sort of simple MET system in your hospital. The principles are that you have symptoms and signs of deterioration that are recognized by nurses and doctors at the bedside, that the bedside staff are empowered to call for assistance without delay. And instead of, in the old days when we used to have, like, the intern would call the resident, or the resident would call the registrar, and the registrar would call the consultant, or the nurse would have to call the registrar, and the registrar would then call the consultant. All of that should be, we should do away with those sorts of hierarchies when you see a child who's deteriorating. And it should be available to anyone, a nurse to call a MET or a resident to call a MET if they're worried about a patient because they think they're deteriorating. You have to have a readily available urgent response with people who have been trained in how to detect and how to manage critical illness. And usually this response, along with the interventions they put in place, improves outcomes, as you saw with the case I presented with Joy. A key feature of the MET system is that all staff should be empowered, that even junior nurses and doctors, and even the parents of children, to summon help without deferring to their senior colleagues or to medical staff necessarily, to summon help, to call a MET call so that you'll get a senior registrar or a paediatrician and a senior nurse at the bedside. There are many different types of MET systems. As I said, I think a simple system is best. Some countries have these scoring systems that they're very complex. I don't think they're good, but I don't think they're any better than just having a simple color-coded monitoring chart and having emergency signs. But regardless of the system you have, many studies have been done showing a reduction in hospital deaths that occur when you introduce a MET system. And it can be a very simple system. I would encourage you to do that. So there are some elements to make it effective. If you want to have a good system, then you have to have these elements. Firstly, you have to listen to parents' concerns about their child's condition. And this is especially true if the child is chronically unwell. We see a lot of children who have a chronic illness, and they're not always, even at their baseline, they're not always normal. And so it's sometimes for doctors and nurses who don't know the child, they might think their baseline is normal, and they may not be able to recognize when the child's deteriorating. And so I think parents know their children best, and we should always listen to parents' concerns if they think their child is becoming more unwell. We should inform parents and carers about the expected clinical course of their child's illness. And so then they can look out for symptoms and signs which could prompt reassessment. And we should teach staff how to use paediatric monitoring and response charts, the sorts of color-coded monitoring charts that I showed you before. And we should teach staff skills in monitoring and attending MET calls. So we need skills in recognition of the seriously ill child, some sort of analytical skills to work out what's actually going wrong. We need practical skills that might be that the child needs another drip, or they need to be put on oxygen, or they need a chest drain, or they need a change in their IV fluids. They may need a number of different things, or they may just need further monitoring. They don't always need intervention, but often they do. But it often requires some practical skills that we need to teach people too. And we also need to teach people communication skills, because usually mistakes are made when people don't communicate properly. So learning to communicate about a child's condition, about how they're deteriorating, is very important. So all of these skills we need to learn. When you're analysing a situation at a MET call or on a ward round, you should think to yourself, well, what is the situation? Sometimes you can get a best understanding of that by talking to the nurse at the bedside, or talking to the doctor who knows the patient. What's the background to this child? What's the diagnosis? Is the treatment the child's on sufficient? So this child that I showed you before, Joy, she was just on penicillin and she was on oxygen. That was her whole treatment. And clearly it was okay for most children who have pneumonia, but it wasn't sufficient for Joy. And we need to ask the question, are there some unrecognized diagnoses or problems that need extra treatment? And what is the nature and the cause or causes of the deterioration of this patient? And what factors can we change? You go to the bedside and you think to yourself, well, what can we change to make things better? And how do we do that? And who else do we need to assist? Sometimes we'll need the anaesthetist, or sometimes we'll need another doctor to assist. But you need to think to yourself, who else is needed to assist, and not just have to manage every situation just by yourself. But that's why you need some analytical skills, and you need some practical skills, and you need skills in communication. Sometimes when we are at the bedside, you might think, well, where do we start in assessing a child to see if they're deteriorating? Well, I talked before about the quick assessment you can do at triage of every child, isn't it? And with good practice, you can do that assessment, the airway, the breathing, the circulation, and the disability or the level of consciousness, usually within about a minute. You listen for stridor, you look to see whether there's signs of upper airway obstruction, you assess the child's breathing, their respiratory rate, their signs of respiratory distress, their tracheal tug, or their grunting, or their nasal flaring, or their cyanosis, their chest indrawing, the intercostal recession, their subcostal recession. You check their oxygen saturation. You assess their circulation. Remember I said you feel their hands and feet, and you feel their pulse rate and the pulse volume, and their capillary refill, and whether their hands are warm or cold. And if you do that in every patient, you get really good at identifying children who are well from children who are unwell. And I think we should be teaching people to do that. so that they get a good understanding of which children are well and which children are unwell or in shock. You assess their disability or their neurology, their response to pain, and their level of analgesia. So remember, in the scenario I described before, as part of the package of things that were done for Joy at the time of the Met call, she had her antibiotics changed, she had some ketamine for a chest drain, she had some ongoing analgesia, etc. And it's not just one thing, sometimes it's many things, and sometimes we need to deal with a child who's in pain. So just think of that. We can review all the child's drugs, check their doses, decide what drugs are no longer needed. We can check the child's temperature and check for other concerning things like nosocomial complications, like is the IV cannula working? Is it thrombosed? Is it ulcerated or leaking? Are there any pressure areas? We can decide whether any laboratory tests are needed. So do we need to check the electrolytes or the creatinine and urea? We can check the child's fluid balance. We can see if there's signs of edema or dehydration. And we can see if we're giving adequate amounts of nutrition or feeding. We can check the child's blood sugar. Is it normal? Is the child on sufficient glucose? If they're feeding, are they on enough feed? And we can check sometimes whether or not the child's got signs of infection on the full blood count, or check to see if they've got clinical anemia, and check for other signs of infection. We can go through the A, B, C, D like that, the alphabet, if you like, and you can have a framework for the assessment of any critically ill or deteriorating child, either on a ward round or if you're seeing the patient in at a Met call, at an emergency call. Sometimes it's useful as part of this. It may not be a real emergency, but I think there are times when it's really helpful to have a second opinion by an experienced pediatrician. Now, sometimes we're used to just running it all by ourselves, and we just see the patient every day and we do the same thing every day. And we essentially have often tunnel vision. What I mean by tunnel vision is we see the same things every day and we don't think more broadly about what's going on. And so I find sometimes it's very useful to have a reassessment or review by a second pediatric specialist if questions remain about a diagnosis or the signs and symptoms are sort of not quite, they don't quite match, if they're atypical, or if the normal resolution that you'd expect to see is not occurring with what seems like adequate treatment. And sometimes at the request of parents, I often get asked to see patients because the parents are saying, well, I'm not very happy with the way the child's going, and we need to get a second opinion. And a second opinion is not something that, means the first opinion was wrong. It's really just often two heads are better than one. And so you can then meet and discuss and decide what you're going to do. That's sometimes done at an emergency, in an emergency situation, but it can also be done in a sort of less emergent situation where a child's not going in the right way and you want to try to detect their problem, what we're missing before they deteriorate. So that's really all I had to say. The main thing today was to talk about the way we can detect deterioration in children and how important it is. If you think about all the conditions we see, almost any diagnosis, there can be a deterioration, and it's up to us to be able to identify it and have systems to do that. So if you don't have some sort of system in your hospital, I think the color-coded monitoring charts are very good, and having some sort of MET system is very useful too. I'm going to stop talking there, but thanks for your attention today, and I hope that's been useful. And I'll stop the recording now. Thanks, everyone.